last one. Okay. So are BOOI and BCI valid in female patients? And the answer is no. Well, not the male version. And I think it's very difficult because, of course, the indices in men were created because it was prostatic obstruction was common. We have a good operation to treat it, TURP, so you could study people before and after surgery with a single condition and lots of patients. Now, you'll appreciate that in women, that's not the case. There are very few women who have obstruction, and there's no single cause and there's no single procedure to reverse the obstruction. So I don't think we'll ever have the equivalent in women that we have in men, because it's just not, the condition is just not common enough. So I think one has to use common sense. And I think the figures that you showed earlier, Anish, of a pressure higher than 20 and a Qmax less than 15 are perfectly reasonable. And I don't think anybody would dispute that. But where the cut point is in women, I don't know. And I suspect we won't know. And of course, mild obstruction probably doesn't matter in the same way that mild obstruction in men doesn't matter. So it's only once the obstruction is causing residual urines with increased frequency, maybe infections, or in your case, which is a little bit unusual, poor compliance, etc., do we need to really worry about it. But by that time, I think it's pretty obvious they have high pressure and low flow that anybody would recognize, and then you treat them accordingly. So that would be my view.
Yeah, perfectly.
Comes up to you, sir. You can just see the question next after
that. The next question is about, well, I'll read the question. What are the issues if calibration is done with atmosphere and in the bladder after catheter insertion? I don't quite understand the question, but I'll say what should happen is that when you set zero to the atmosphere. You do not set zero to the patient's bladder. So at the beginning of urodynamics, your pressure should read the true pressure, because we're measuring physiological measurement. In the same way, if we were measuring something in the respiratory tract or in the cardiovascular tree, we would want to know the real pressure. So it's completely wrong from the principles of physiological measurement to start with the bladder and the rectal pressure being zero, because that's not what it is. That's not physiological measurement. However, you can have the catheter in the bladder and still zero to atmosphere, but then you have to turn your three-way tap so that the bladder is cut off. That's acceptable. What is not acceptable is to have the bladder in continuity with the transducer when you set zero. Yeah, I hope that's clear.
Yeah, you have the next question coming up, so okay. You can just look at that, please.
Then for quality control during urodynamics, when we use cough, what's the amplitude of the cough that we'd be happy with? And what difference do you accept between PVES and PABD? Well, that's a good question. I think from a practical point of view, you probably need a cough which rises above the baseline by about 20 centimeters of water. I mean, the average coughs we get are probably between 20 and 60. So you can get some patients, particularly smokers or obese patients, when they cough, they can have very high pressures when they cough. And obviously the two pressures should be the same. The pressure increment in the bladder should be the same as the pressure increment in the rectal catheter. Now we say that providing they're within 70% of each other, so if one is 70 and one is 100, that's okay. But we made that number up. It's not a scientific statement, but we find that if we find that, then the quality is adequate for us to do a good urodynamics. But usually they should be very similar. So maybe 90 and 95 centimeters of water, 65 and 60 or something like that. But if it's 40 and 20, then you need to work out why that is occurring. You need to make sure the catheters are in the right place, that you flush the catheters, and make sure, of course, that you set up the system properly, atmosphere, um, uh, validating the pressure to atmosphere, make sure your transducers are on the same horizontal level.
Dr. Paul, you have the next question.
Where am I going? What do I think about non-invasive diagnostic tests for obstruction? Well, we talked about that a little bit, didn't we? And we said the problem with urine flow studies is that even when they're below 10, which is recognized by everybody as quite low, there is still a 30% chance they do not have obstruction. And all the proxy tests, what I call the proxy tests, which aren't real measurements of either pressure or flow, like detrusor wall thickness, prostatic intrusion into the bladder, these are proxies, and their accuracy rate is going to be much less. There are also some of them, like detrusor wall thickness, very difficult to standardize and very dependent on the person that's doing the investigation. So I think at the moment there is no alternative. As the EAU says, that if you want to diagnose prostatic obstruction, bladder outlet obstruction, you have to do pressure flow studies. Hopefully we will have a non-invasive method of measuring obstruction. But we had a workshop about that last year at the ICIRS, and unfortunately nobody is near producing a solution to that. There are ideas, but they're not practical in the clinical situation at the moment.
Dr. Paul, the next one is on your screen, please.
The question is basically a 70% test, 70% accuracy test acceptable? Well, I think I would just turn the question back on you. If you're a man, if you're a woman, then hopefully you care about men. But if you're a man and you're faced with having a possible prostate operation, are you happy with a 70% chance? Personally, I would not be happy with that. That's not good enough for me. I think a clinical test should be a lot better than that. And as we have a clinical test, which, provided it's done properly, gives excellent reproducibility if you repeat the test twice, and therefore I know whether I'm obstructed. So it depends on your personal philosophy. And certainly I'm not, if I tell patients, well, this test is only 70% accurate, most of my patients will say, haven't you got a more accurate test than that? So I think that's what, when I ask a group of urologists, if you were going to have a TURP, if your father, uncle, brother, cousin was going to have a TURP, would you like them to have pressure flow studies first and prove that they were obstructed? And everybody puts their hands up. I've done it in India. It was exactly the same.
Anish sir, you need to stop sharing the screen, sir. Dr. Paul, the next was coming to you. I think we'll have 2 or 3 more questions and then we...
Okay, so the next one is, can we take a decision based on cystoscopic findings of a high bladder neck? I assume you mean that a high bladder neck indicates obstruction. Well, I'll tell you a really sad story. And that goes back to the 1960s in Bristol, where they had a lot of interest in adult enuresis, and these were often children who became adults and were still enuretic. So they endoscoped them, and I'm talking largely about young men. They endoscoped them and they found this high bladder neck, and they incised the bladder neck, and it made no difference to their enuresis, because of course, if they have detrusor overactivity, which these young men had, then you do get a high bladder neck as part of global detrusor hypertrophy, because they also had detrusor overactivity during the day, which was the cause. So these patients characteristically, if you did urodynamics on them, have extremely high flow rates. And when you endoscope them, they have bladder, they have bladder trabeculation, and the high bladder neck is part of that. So they cut the bladder necks. This one surgeon who took an interest to cut the bladder necks. And of course, they then, lots of them had retrograde ejaculation. And as they were relatively young men, usually around the age of 20, that made their future lives very difficult. So the answer is no. if your urodynamics is equivocal, you probably don't need to do a prostate surgery because they haven't got significant obstruction.
Dr. Paul, the penultimate question for you on your screen, please.
Yeah. How to diagnose obstruction in a patient with DU on urodynamics, because perhaps they have both detrusor underactivity and obstruction. Well, it's a good question, but if you use the two indices, then you will have a bladder outlet obstruction index above 40, maybe 50 or even 60, and you will have a bladder contractility index below 100. Now, obviously, if you've got severe obstruction, you can't have detrusor overactivity. Well, you can have it, but you won't be able to pass urine. That makes sense, doesn't it? So you never see severe obstruction and severe detrusor underactivity in urodynamics. So urodynamics is the key, and just use the two indices, the obstruction index and the contractility index. And you will certainly find some patients who have both, an element of both, and I think it's reasonable to offer them TURP.
Dr. Paul, the last question on your screen, please.
Well, yes. I think this is a very good question, and we really need a good quality study in men who've gone into retention as to the value of urodynamics or not. Now, myself and my senior colleagues have always followed the principle that if a man comes in urinary retention, and providing they have a bladder which is not too big, in other words, not a 2 litre, not a 3 litre bladder, but a bladder with perhaps the retention volume between, say, 700 and 1,000. If they fail 2 trial without catheters, then we will do a TURP on them. And it's our impression, and I say our impression, our belief that these patients do well. But that's not good evidence. So there really needs to be a good study. And why not USI encourage your colleagues to do a collaborative study in which urodynamics is done on all retention patients and you look at the outcome? Because there has been a little bit of work to say that if we did urodynamics on the type of man that I described, you would see an attempted voiding contraction. So when you took the catheter out, you filled the bladder, and they said, I'm full, and you said, okay, try and void, you would see a contraction. But of course, with somebody who's had a catheter in, you don't know how it changes everything. So if you see no contraction, you don't really know whether the patient would have been able to do a contraction had they not had a catheter in for 2 weeks, 2 months, or whatever. So a good quality study, I think, would be very valuable for our practice.
So Paul, way back about 15 years ago, we did this study in our center here. And the title of the paper, which was published in British Journal of Urology, was...
Oh, let's look it up. Is it with your name?
Yeah, the need, defining the need for doing urodynamic studies in patients who come with retention.
Yeah.
So this was, I think in 2006 or something, we published this paper. And that is where we defined 2 kinds of bladder with retention who had huge volume without a pain, any history of pain. So painless retention and upper tracts preserved. And in the other group, those who generally presented with the pain and upper tract deterioration. So that is where we, that is where we actually finally concluded that those who have got painless retention and preserved upper tracts, we need to do urodynamics. Those who have already got pain, large bladders, and upper tracts compromised, probably we don't need to do urodynamic study. So this is 15 years ago, I published in British Journal of Urology.
Yeah, that sounds similar to the work we did on chronic retention.
Yeah, chronic retention, yeah.
Yeah, when we identified 2 groups of patients.
Yeah.
Like, as you say, one with no compromise to the upper tracts. Usually they had bigger bladder volumes.
Yeah.
And they were painless, but also the high pressure chronic retention, who were also painless. But when you examine the patient, the high pressure chronic retention, it felt like a uterus.
Yeah.
was hard. Whereas the low pressure chronic retention, it was quite difficult to feel, and you had to percuss it. You could percuss it, but you couldn't feel it so well. Now, when you did surgery on those two groups, the low pressure chronic retention didn't do very well. They never emptied their bladder.
Yeah.
Whereas the high pressure chronic retention did do well, and they emptied their bladder and their symptoms resolved.
Anish, can I ask one last question?
Yeah, please.
Yeah. Paul, this is something a quick one. Patients undergo unexplained retention, say for example post-operative retention, and you decide that you remove his catheter on Thursday. Somebody says no, do it on Sunday. Have you any criteria in your mind to say this is the right time to remove his catheter and give it the first warding trial?
Well, I think the scenario this comes up in a lot is joint replacement, hip replacement in particular.
Correct. Yeah.
So this is a big issue, and I think that there needs to be a study on this, and we did actually write a protocol for such a study, but we couldn't get it funded for a number of different reasons. And in this, patients would be randomized to an alpha blocker given from a couple of days prior to surgery, carried on for a week, and you would take the catheter out whenever the patient was mobilized. So that was the basic premise of it, to look and see whether it made a difference. Because the problem with men who come in and have a hip replaced, sometimes they have no symptoms at all, even though they've got an obstruction. Those that come in who have got symptoms, often the symptoms are due to overactive bladder and there may be no obstruction. So you've got a complete mixture of patients, and you don't really understand why people go into retention.
Would clamping help?
Pardon?
Would clamping a catheter help?
Old practice.
That's what we normally done quite often. I mean, all non-urologists and non-functional urologists do that.
Well, and of course, it also depends on the anesthetic that the patient has during the surgery. So the orthopedic surgeons, as you know, don't like catheters because they worry that there will be an infection and then the infection will go on to the prosthesis. So they really try to avoid having catheters. But certainly a catheter for 24 hours, I think is good medicine, really, because patients hate to be catheterized afterwards. It's not a pleasant experience. But I think it would be sensible to do it under, say, tamsulosin cover, because as long as they had no cardiovascular reason, that's pretty low risk. And it would, as we know, help them to avoid.
Anish, sir, closing comments from you, sir.
Yeah. So, friends and speakers, my colleagues, and especially Professor Paul Abrahams, words shall fail to express my gratitude to you.
Thank you very much.
Thanks a lot. And he's on the screen, I can see 1,000 participants.
1,000?
Really?
Yes.
1,000?
Yeah,
1,000 participants.
My goodness. Yeah.
So kudos to you. It is because of you that we have such a great gathering here. And I'm sure everybody who has listened to this will definitely get a very good idea about, how the LUTS should be treated across the age group, right from children to adults to females. And then they can, further build up their knowledge with little bit of reading. So I think it is all because your magnetic personality, your presence, that it has been a great success.